I am Dr. Rahul Patil, Consultant Cardiologist, Ruby Hall Clinic, Pune, practicing here for last 12 years since 2006. I am predominantly practicing as an interventionalist, doing radial root angiographies and angioplasties. But in last 10 years of my career, I have seen so many patients with resistant angina, not amenable for optimal medical therapy, revascularization. I was looking for some therapy for them which could be non-invasive and could relieve their symptoms. So today I have brought in front of you a new therapy called ESMR, which is Extracorporeal Shockwave Myocardial Revascularization. It's a scientific treatment for no-option patients requiring angioplasty or bypass surgery and who are not suitable patients. Before going to the presentation, I would like to highlight few cases in front of you. The first case is 78-year-old gentleman, diabetic, atrial myocardial infarction in 2015. Post-lysis, his ejection fraction is 28%, and he continues to have effort angina and breathlessness. His coronary angiography done 2 years back showed triple vessel disease, and he was advised bypass surgery. Now he is 80 years old and he is not willing for further conventional bypass surgery. The second case is 67-year diabetic female with effort breathlessness in 6 months. Her vitals are stable. There are few basal RALs with left ventricular third heart sound. ECG shows poor R wave progression. Echo shows dilated left ventricle with global hypokinesia and ejection fraction of 20%. Her kidney parameter shows that her urea is 62, creatinine is 2.1, and when we calculated her eGFR, it turned out to be less than 30. And she was advised angiography with high risk, saying that she may develop contrast-induced nephropathy. So she was reluctant to go for angiography. The third case, this patient is a 67-year hypertensive old gentleman, history of old inferior wall myocardial infarction. His old angiography 12 years back showed RC 100, LCX 80 and LAD 75%. And patient underwent bypass surgery with 3 grafts 12 years back, but continues to have effort angina for almost 1 year, which is progressively increasing. His CT coronary angiography showed graft occlusion. For this graft occlusion, the graft occlusion was predominantly on the RCA and circumflex, and patient's LAD graft was functioning well. This patient was subjected for angioplasty to OM and RCA, and the angioplasty for this total occlusion was failed, and the patient was advised redo surgery. Despite optimal medical therapy, patient continued to have ongoing angina, and that's the reason why we subjected this patient for ESMR. The cases which I showed you, there are similar type of no option cases which can be seen in your clinical practice, like triple vessel disease with renal failure, triple vessel disease with severe ischemic dilated cardiomyopathy with increased surgical risk of bypass surgery, triple vessel disease with bilateral or unilateral carotid artery disease with high risk for bypass surgery, post-CABG status with occluded graft carrying high risk for redo surgery, severe instant restenosis in a stained patient who is not willing for bypass surgery, any patient who is not willing for bypass or angioplasty due to high risk for the procedure, or failed angioplasty in a chronic total occlusion or a calcified blocks. So these are all patients who continue to get angina despite angioplasty or bypass surgery are candidates for some kind of therapy after optimal medical treatment. So I am showing you a paper of American Heart Journal of 2002 which shows that persistent angina is seen in patients despite revascularization procedure like angioplasty and bypass surgery. There are 5,500 patients evaluated in this study which showed that 30% of bypass patients and 20 to 34% of angioplasty patients continue to get angina despite revascularization and despite optimal medical therapy. So after knowing the patients who are resistant angina patients not amenable for regular interventions in the form of bypass or angioplasty, I think we don't have any other evidence-based therapy remain for these patients except for ECP. So EACP is a therapy which has been practiced in India for a long time, where the cuffs are applied to the patient's calf and thighs, and patient is given compression in their thighs so that venous return to the heart improves and it improves collateral circulation. And this therapy has been practiced, but the results are still question marked. Now I am going to discuss with you new therapeutic option in managing ischemic heart disease, the role of ESMR in the treatment. Why ESMR? So occlusion of small coronary arteries other than major arteries like LAD, circumflex and RCA. There are small branches which are less than 2.5 millimeter in size, and these arteries are difficult to do bypass and angioplasty. So these are the arteries which can be culprit for giving angina. Then there are many small twigs and branches which remain untreated in angioplasty and bypass surgery. Then in a patient whose major coronary artery is occluded, which is chronically totally occluded, which are difficult to treat by angioplasty. So such all cases can be treated with ESMR. So the aim of treatment is to relieve the patient's angina without conventional revascularization, inducing local angiogenesis at myocardial ischemic areas using low intensity non-invasive focused shock waves. The background of ESMR is shock waves are special acoustic waves that can be targeted and focused non-invasively to a selected area inside the patient's body. Shock waves therapy has been used long years back. It has been tested initially 20-25 years back for treatment of kidney stones in the form of lithotripsy. And this lithotripsy was found to be absolutely successful, and most of the kidney stones are broken by high intensity shock waves. And the similar type of shock waves are used in ESMR, but the intensity of shock waves are less, and these shock waves can be precisely given to the area of a myocardium which is 2 millimeter in size. So you can look into the graph. In 1980s, urology was the therapy where shock wave therapy was used in lithotripsy with 900 bars to break the stones in ureters and kidneys, while in orthopedic it has been used for plantar fasciitis, and this therapy was evaluated thoroughly in 1990s, and 400 bar shock waves were given to relieve the pain of plantar fasciitis, and which has also been successfully given by most of the orthopedicians across the country. In 2000, these shock waves were evaluated for cardiac treatment in a form of angiogenesis, and subsequently this treatment was targeted specifically for heart. Now the slides which I am showing you is a shock wave cup. This shock wave cup is being connected with high voltage line, and the electrode in this shock wave cup has generates a spark, and this spark generates a focal shock wave in an area of 2 millimeter to the heart in a form of magnifying glass effect, and this shock wave can be targeted precisely to the ischemic zone, and the zone which is nearby to the viable myocardium and ischemia. And if we generate shock waves in this area can regenerate new blood vessels in a form of angiogenesis. There are various in vitro and in vivo studies which has been done since long years, from 1993 to 2007, and this studies has been evaluated by various doctors all across the world, and they found that shock waves, they cause vasodilatation, they also generate shear stress in the myocardium, they increases nitric oxide synthesis, they do have anti-inflammatory action, neovascularization, increasing the intensity of vascular endothelial growth factor in the myocardium and blood vessels, and so on. And it also inhibits poor remodeling of myocardium. So this ray diagram tells us that extracorporeal shock wave causes release of endothelials of nitric oxide synthesis. This in turn increases nitric oxide in the blood circulation and perhaps reduces inflammation in the myocardium, and also helps in neovascularization of, and angiogenesis effect is seen in the most of the myocardial cells. So these are the slides which shows that compared to control, the shock wave therapy increases blood vessels in the histopathology slide, also increases enos, VEGF. These are one of the factors which are helpful for increasing neovascularization of the myocardium. So this is one rapid study which was done in 2003, long years back, before the study has been, before the shock waves have been evaluated in the myocardium. This was used for orthopedic purpose, and it was found that after giving shockwave compared to control, there was neovascularization found in the tendon bone junction as in rabbits, and subsequently it was also found that vascular endothelial growth factors was found to be high in patients with shockwave therapy. Then in vivo study was done especially in pigs, and this study was done in myocardial to evaluate dysfunction of myocardium following clamping of coronary artery of the pig's heart. And these are the initial studies which were done to evaluate the effect of shockwave in patients with ischemic myocardium. And there were 16 pigs were involved, and they found that there was the blood supply to the myocardium was increased after 4 weeks of therapy after shockwave treatment. And they also found that the collaterals to these myocardiums were increased in patients who were given in subjects of pigs where shockwaves were given. So these pigs were further evaluated by histopathology, and it was found that the number of capillaries were increased in patients in pigs with shockwave therapy compared to the control pigs. And there was improvement in ejection fraction, and which was statistically significant. From 40% it has improved to 55 to 60%. And there was also improvement in the regional myocardial blood flow from endocardium to epicardium throughout the muscle mass. There was increase in number of capillaries and blood supply to the myocardium. The side effects were also evaluated in animal studies, and it was found that 24-hour Holter evaluation CKMB, which tells us that any pig which has developed myocardial infarction or there was any hemodynamic abnormality seen after the therapy, but there was no side effects seen in animal models. After these successful animal model studies, the human studies were done in patients with ESMR, and the experience of humans were done all across the world with multiple center study, and it was a prospective randomized double-blind trial. And this trial came in 2011. This was a multi-center study, and this trial concludes that the data shows that the ESMR is an effective non-invasive method of treatment for myocardial ischemia in stage coronary artery disease patients. And 435 patients were enrolled in this clinical trial, which was double-blind trial from various institutes across the world and various cities and countries from Germany, Russia, Japan, China, Israel, Pakistan, Taiwan, Italy, and so on. And after enrolling these patients, there was treatment protocol was set, and in this treatment protocol, the therapy was given for 9 weeks. First week, the therapy was given for 3 weeks, and there was a gap of 3 weeks in between, followed by on the 5th week, 3 shockwave therapies were given. Subsequently, there was again a gap of 3 weeks, and then on 9th week, there were 3 shockwave therapies were given, and precisely the ischemic zone was determined through 2D echocardiography and color Doppler, and 500 to 1000 shocks were given to the ischemic zone. At each treatment session, shockwave should be delivered to the border of ischemic area, triggering the viable tissue for angiogenesis, and that was the mechanism how it helps over a period of 9 weeks of ESMR therapy. There were certain inclusion and exclusion criteria which were set for the patients of this trial, and the inclusion criteria were the viable myocardial segments with reversible ischemia and or hypernation need to be determined before enrolling the patient. Patient should be on optimal medical therapy for 6 weeks. There should be absence of any acute clinical event for more than first month of enrollment. There should be optimum acoustic window for 2D echocardiography to visualize the heart. There were certain exclusion criteria like any active coronary inflammatory process, like any acute coronary syndrome was contraindicated. There should not be any acute myocardial infarction within 3 months of presentation for ESMR. There should not be any intraventricular thrombus, no pregnancy, any malignancy in the area of treatment. Inability of adequate echocardiography window was also one of the prerequisite of exclusion criteria. Tissue analysis was done with stress echocardiography. Before enrolling the patients, it was confirmed by echocardiography whether the area of myocardium is normal, ischemic, viable or non-viable like necrosis or infarcted myocardium. And this was done in a form of assessment of a myocardium by stress echo, presence of hypokinesis, akinesis and dyskinesis on stress and normal echo tissue on rest suggests that the myocardium is ischemic. Akinesia on rest and hypokinesia or normal on stress suggests that it's a viable myocardium or a hibernating myocardium, or rest echo or stress echo showing akinesis and dyskinesis says that the myocardium is dead and necrotic. So such patients were excluded from the study. The subjects were further evaluated for the outcome, and the outcome was evaluated by 4 ways. The first was improvement in Canadian class of angina, and in this it was found that the mean improvement in anginal class was almost 35%, and few operators also found that the improvement was as great as 50% in the reduction of angina. There was increase in exercise tolerance capacity, and this was found to be almost 35% in most of the studies, and various operators on an average showed that the improvement was almost 35%. But 2 of the operators found that the improvement in their study was found to be 60% in improvement in exercise tolerance. The weekly sublingual nitrate intake was reduced by almost 80% by most of the studies, and the subjects found that they were relieved of angina and the requirement of sublingual nitroglycerin was reduced. The subjects were also evaluated for improvement in ejection fraction. This is something very subtle and very important in evaluation of a patient of coronary artery disease. Improvement in ejection fraction was found to be almost 11%. As you know that ejection fraction of a normal heart should be more than 55%. And every 10% decrease in ejection fraction reduces the class from mild to moderate and moderate to severe. Ejection fraction less than 40, less than 50, and in between 40 to 50 is mild LV dysfunction. 30 to 40 ejection fraction is moderate LV dysfunction, and any ejection fraction is less than 30% is severe LV dysfunction. So if ESMR improves ejection fraction by average of 10 to 15%, you are definitely going one class above in improvement in ejection fraction from severe to moderate, moderate to mild, and mild to normal. There was also improvement in myocardial perfusion, and myocardial perfusion was studied with PET scan and SPECT scan, and it was found by most of the study investigators that the improvement in perfusion was almost 33 to 35%. So these were the clinical parameters which were researched in this clinical trial. One was angina pectoris class, second was myocardial perfusion by SPECT or PET scan, exercise tolerant capacity, and weekly nitrate intake. These are some of the SPECT scan reports of these patients which were evaluated in this clinical trial, and compared to pre and post 6 months, it was found that the symptom class has also improved, and the perfusion SPECT scan also shows that there is improvement in the perfusion of a myocardium. And similarly, the second case also shows that the infraposterior wall myocardial blood supply has improved after 6 months of therapy with the help of SPECT, and it has been thoroughly evaluated. So concluding the ESMR, it's a safe therapy. There are no arrhythmias, no cardiac enzyme rise, no tissue damage seen on MRI, no device-related side effects were reported. There was improvement in the parameters of the patients. The CCS class and NYHA class was improved. Exercise tolerance capacity was also improved. The anginal threshold at exercise was more. The myocardial perfusion shown on SPECT and PET scan was better. Local contractility was improved on stress echocardiography. The quality of life as per questionnaire was also shown to be improved. Describe you how this ESMR therapy has done in patients and what are the instruments required for doing this therapy. So the ESMR machine with a monitor and a 2D echocardiography is must for doing ESMR therapy. Here the patient is subjected without local anesthesia without any intra-cap. On outpatient basis, patient walks into the OPD, he lies on the table, and this natural repair mechanism is triggered with the help of this shock wave. These shock waves, if you go through a echocardiography, the shock wave is localized precisely to the area of myocardium with the help of a scale which is given on a machine, and through the chest wall we measure the depth and width of the left ventricle, and we precisely focus this shock wave in the area as shown in this focal zone alignment with the help of echo probe and ESMR probe. There are a lot of successful installations of this ESMR worldwide. There are 60 medical centers worldwide with this therapy where this therapy has been available. It has been approved by European FDA, Australian FDA, South Asia, Singapore and Malaysian FDA, Canadian FDA and Japanese FDA. So this therapy has been approved as a no option patients where conventional therapy like angioplasty and bypass surgery has been rejected or very high risk for the patients. There are various training centers in Germany and Netherlands which train doctors for doing ESMR. Till now, there are 23 clinical trials past and current going on. There are 6 publications in peer-reviewed journals which are presented in International Cardiology Congress like ESC, APSC and 2010 and 2012. Now discussing on treatment procedure, coming to the highlights, the CardioSpec is safe, cost-effective and user-friendly system with proven results and efficient technology. Large focal zone, fast treatment time, total transmural coverage and optimal therapeutic effect. Unique system configuration, which is real-time treatment view. Precision of localizing system, high success rates and safety of treatment. Custom-made ultrasound configuration, and the shock waves are R-wave gated. The treatment requirements are equipment in the form of CardioSpec system, disposables, technical support, a trained staff in ESMR and proficient in echocardiography, sufficient number of patients, pre-treatment testing and patient agreement for the procedure of 9 weeks. The principles are low energy focused shock waves, focused and controlled by echocardiography, and they are ECG gated and triggered only with ECG. The protocol, as we discussed, they are for 9 shock wave therapy with the interval of 3 weeks, without anesthesia, without hospitalization on outpatient basis. There are a lot of benefits of ESMR as it is non-invasive. Just require an echocardiography and a cardiologist. Easy to use, fast treatment procedure in 30 minutes time, and we can comfortably do this therapy on outpatient basis. There are no side effects in the form of arrhythmias, embolism, and there are no retreatment limitation for the patient. So to summarize ESMR therapy is complementary to existing therapies for angina by inducing development of collaterals to compensate for the lack of blood supply to the occluded coronary arteries. ESMR therapy could accurately and non-invasively be applied to the border of ischemic zone established on echocardiography. ESMR is an alternative therapy to existing methods like EECP. ESMR therapy could be an adjunct therapy to existing revascularization procedures, and it is very effective. My own experience about ESMR is for last 2 years. I have done around 100 patients till now. Most of the patients are elderly in 70s and 80s. Those patients who are not suitable for angioplasty and bypass surgery, or who carry very high risk for the procedure, those who have been rejected by the surgeon, those who have been rejected due to their clinical condition like poor left ventricle, renal dysfunction, patients who have associated carotid artery disease, patients who have undergone transplants. So these are all the patients who are no option patients for conventional therapy like angioplasty and bypass surgery. So these all patients were subjected and were pre-tested with their symptom class, their 6-minute walk test, their SPECT scan,
which showed that the perfusion of a myocardium was poor in particular area. The ejection fraction was evaluated before subjecting them for ESMR, and my outcome of my more than 100 patient is phenomenal. That is, most of the patients showed improvement in symptom class, decrease in requirement of nitrates, improvement in exercise tolerance. The SPECT scan post-therapy also showed improvement in the perfusion of a myocardium, and there was phenomenal improvement in the quality of life of the patient. So I would recommend this therapy for patients who are not suitable for angioplasty and bypass surgery, or who are very high risk for the conventional therapy, and those patients, despite optimal medical treatment, continues to have angina, will definitely recover from this therapy.
Now I will take you through some review of literature. Now there are various clinical trials which has been published in international journal. Now this paper is of extracorporeal shockwave therapy in severe coronary artery disease unsuitable for PCI and CABG, a single center experience. Now talking about the conclusion of this study says that ESMR is feasible and effective in patients with coronary artery disease unsuitable for PCI, and most of these studies has been studied with SPECT scan. Now the second study is in European Heart Journal, and this study was published with the headline of ESMR, which reverses ischemic related left ventricular dysfunction and remodeling, and it has been assessed. Molecular, cellular and functional assessment was done. It was found in the conclusion that ESMR therapy effectively reverses ischemia elicited LV dysfunction and remodeling through enhancing angiogenesis and attenuation of inflammation and oxidative stress. The third paper is again in European Heart Journal, a new treatment for patients with refractory angina, ESMR. Now this paper evaluates 15 patients of severe symptomatic coronary artery disease, and the conclusion says that our data, even if it is preliminary and limited, documents a definite improvement in terms of perfusion, functional and clinical benefit in very difficult subset of patients. So let me tell you, these all patients are very high risk patients which has been evaluated, very resistant patient, and thoroughly evaluated with SPECT scan. This is a paper of Coronary Artery Disease Journal in 2012, where ESMR has been evaluated in patients with symptoms with LV dysfunction and refractory angina, and this also therapy was evaluated with serial MRI imaging and showed improvement in the patient class. Again, a similar paper in coronary artery disease. There is one paper in Heart Failure Journal in 2010 which shows the initial clinical experience of ESMR in treatment of ischemic heart failure. The conclusion of this paper says that there is significant improvement in patients with symptoms of heart failure, and there is improvement in ejection fraction of the patient, and which has been evaluated by stress and rest perfusion imaging. One more paper in Journal of American College of Cardiology, which evaluated echocardiography guided ESMR therapy for refractory angina, which improves regional myocardial blood flow, and these papers thoroughly assess the patient with PET imaging. And the conclusion of this paper says that the 16 patients were evaluated, which were the resistant angina patients, and the shockwave therapy improved symptoms in patients with chronic refractory angina. Regional improvement in myocardial blood flow was shown on PET imaging.
Thank you very much.
Now I will present you how to do a ESMR in a patient. Now this gentleman is a 66-year-old, 12 years bypass surgery in past, and have ongoing angina, and this angina is persistent and is unable to walk even for a short distance. His chest pain is on and off since 2-3 years. Recently he has been evaluated by coronary angiography, and it showed that there are two grafts which are occluded. The RCA and OM graft is occluded, and the patient was subjected for angioplasty to OM and RCA, which has chronic total occlusion. Both the angioplasties, especially on the OM, the angioplasty was failed, and the patient was left alone with medical treatment, and despite optimal medical treatment, this patient continued to have angina. Now, this is a patient who becomes a no-option patient where lima to LED is functioning, but the small grafts of OM and RC are occluded, and despite this, there is no surgical chance or any other procedure which can help this patient to relieve angina. So, in this patient, we are doing ESMR and we are planning 9 sessions for him. Following instruments are required for ESMR. This is a ESMR machine which is ECG gated, fully computerized, which holds the echo probe, and the 2D echo machine is connected to this ESMR machine, and the echo probe is located over the chest wall, and you directly gets the left ventricular frame on echocardiography, and we apply a ESMR probe. This is what we call as ESMR probe, and which has a capacity to deliver shockwave. After determining the area of ischemia, we give shock waves to the area which are adjacent to viable tissue. So in this case, we have determined several areas of the heart, and the shock waves are delivered to the particular left ventricular wall which is not getting adequate blood supply.
Screen से correction.